Good morning students, good morning one and all. Today we'll be talking about pulp protection. Today the class will be about pulp protection. I'll discuss this under the various contents like what are the pulpal irritants, protection in shallow and moderate cavities, pulp protection in deep cavities. In that we'll be discussing about indirect pulp capping and direct pulp capping and the materials used for pulp protection and any latest materials that have come for the treatment of pulp protection. We'll be discussing all these contents. So you are all aware that pulp is a soft connective tissue that is present in the roots or canals of teeth. Okay. So our main aim or objective here is to protect this pulp tissue from various irritants that are present to the pulp. Okay, what are these irritants that normally the pulp will encounter? Okay, so one of the bacterial irritants. These bacterial irritants you can get it from dental caries. The common problem is dental caries. From dental caries, when the caries is too deep or very close to the pulp, so these irritants can affect the pulp. At the same way, we have periodontal disease because of plaque and calculus. When there is plaque and calculus deposition, which can lead to gingival irritation, and then this infection starts and progresses to the periapex, leading to periodontal abscess and pockets. So even this is an irritant to the pulp. And third is trauma. Any form of trauma, direct like acute trauma or chronic trauma because of parafunctional habits like bruxism also, then can lead to trauma to the pulp. At the same time, direct trauma like road traffic accident or can also affect the vascularity of the tooth and can make the tooth become non-vital. So this can make the pulp necrotic. So, and during procedures also. Okay, there are a lot of procedures that we do in the operative dentistry, like cavity preparation, impression taking. Okay, so during cavity preparation, there is a certain amount of heat that is built up when you don't use a proper coolant. Okay, so and the amount of pressure that you are using onto the tooth during crown preparation or cavity preparation, all can lead to excess heat generation that can affect the pulp. Okay, and second thing is, here we'll talk about something that is very important, is remaining dentin thickness. So this remaining dentin thickness is that amount of dentin that is present between the base of the floor, that is base of the cavity or floor, to the pulp horn. So this remaining dentin thickness will determine us what type of protection or barrier has to be placed to protect the pulp. Either you need a varnish, either you need a liner, or you need a sub base. Okay, this will be determined by the remaining dentin thickness. So even procedures like orthodontic movement also can have some amount of effect on that. And we use lot of chemicals in the oral cavity, like even temporary and permanent fillings like base liners. These, though they are used for protection, even they are chemicals, even they can affect the pulp if a proper sub base is not given to that. Okay, what are the prime factors are for good restorative dentistry? First is the preservation of the health of dental pulp. Second is non-irritating restorative materials with suitable physical properties. Third is effective barrier to protect pulp from harmful effects of present filling materials. So a good restorative dentistry should encompass or take care of all these things. First is the preservation of healthy of dental pulp. Any procedure that we do should see that you are protecting the pulp. Second, all the restorative materials that you use should be non-irritating and suitable with suitable physical properties. At the same time, they should be non-irritating to the pulp. Okay. And third is, if at all you are using any restorative materials, they should be protected from the pulp by giving a good barrier. Okay. So how can we achieve this goal of giving pulp protection to the pulp? So for example, when you have a moderate caries lesion, we either go with liner or base or varnish. Whenever you have a deep caries lesion, you go either with two procedures, that is direct or indirect pulp capping. Okay, let us now talk about direct pulp capping. So what exactly is direct pulp capping? It is a procedure wherein a biocompatible material is placed over the exposed pulp to maintain the vitality and promote healing. Okay, why do you do this? You do this to maintain the vitality of the remaining pulp tissue and also to prevent from root canal treatment and also help conservation of tooth structure. Okay, direct pulp capping is that procedure when you are working on the when you are excavating the caries, and during that process inadvertently there is exposure. So how you treat that exposure is called direct pulp capping. Okay, let us see let us see about this procedure, how we are going to do. Okay, whenever there is a small exposure, mechanical exposure, either during tooth preparation. Okay, this exposure has to be very pinpoint. It has to be minimal exposure. Okay, and the bleeding should stop immediately. When the bleeding stops immediately, and you have to isolate the area immediately, and then after isolation you have to place a small pellet of cotton onto the exposure site, and once the bleeding is stopped, then immediately you should have to place a pulp capping agent, that is called dical. Dical is a base-based, catalyst-based two-phase system cement that sets immediately on an application onto the exposed pulp area. So this dical is mainly a calcium hydroxide based cement that helps in the formation of reparative dentin. So how does the procedure is done? So either you administer first a local anesthesia and then isolate it under a rubber dam. Even if you are not using a rubber dam, and during cavity preparation, if there is an exposure, you have to isolate it with cotton rolls immediately. That is the first thing which you are supposed to do. You isolate the cavity immediately, see that there is no salivary contamination. As you all know that there are millions of bacteria present in the saliva. So you have to protect the cavity from salivary contamination. Once, then place a small pellet of cotton onto the exposed site and see that the blood is stopped immediately. If the blood is bright red in color, so it is an indication that there is a good amount of inflammation, which may not be a suitable case. If there are pain or continuous pain also, it is also not indication for direct pulp capping. So these such things may go for root canal treatment. So after you isolate the cavity, after you place a small pellet of cotton over that, a few of them recommend the disinfection of the area with hypochlorite or saline. I think saline is more preferable, as you know that sodium hypochlorite has a certain caustic effect on the pulp. So after placement of this disinfectant in the cavity, then you place dical, which is a base-based catalyst-based, mix directly onto the exposure site, and then you can place a temporary restoration over it. You can give an interim restoration such as zinc oxide eugenol for 6 to 8 weeks, because you know that zinc oxide eugenol has an iodine effect. When I say iodine effect, that is, it has a soothing effect on the pulp. So you can give an interim restoration, and after a period of 1 or 2 months, then you can go with a permanent restorative material. If there are no signs and symptoms of pain, if there are signs and symptoms of pain that arises within this period of time, then you can either go for pulpectomy. And pulpotomy is not as such advised, because the success rate of pulpotomy is less. You know, pulpotomy is only removal of the superficial layer of the pulp for 1 to 2 mm, again followed by placement of medicament. The main purpose of this procedure of direct pulp capping is that you try to form reparative dentin. Okay, reparative dentin is formed there. So next we'll talk about indirect pulp capping. Indirect pulp capping is a procedure wherein during a caries excavation there is a possibility that there could be exposure. So in such places, it is best avoided to remove all the infected dentin and leave the affected dentin there. So when you remove all the infected dentin, you are removing all the bacteria laden. Infected dentin, as you know, doesn't have a organized collagen structure. Okay, it is teeming with that infected dentin is soft and teeming with bacteria. Whereas your affected dentin is very hard in structure. Okay, it can be left behind. It has the chances of remineralization if left behind. So you remove all the infected dentin and leave the affected dentin, and then you place a medicament. Either there are different types of medicaments, as we talked about. One is dical, second is MTA, we have biodentin also. So out of these three, these three are the most commonly used biocompatible materials for pulp capping. So you can place any one of the material over the exposed side in direct pulp capping, or in indirect pulp capping you just place it the material to help in the reparative dentin formation. Okay, so so where there are certain indications for indirect pulp capping. When you plan for indirect pulp capping, you have to see that the deep carious lesion is near to the pulp but not involving the pulp. And second, there should not be mobility of the tooth. There has to be no history of spontaneous toothache. There has to be no tenderness to percussion. As you know, whenever the tenderness to percussion is there, it indicates that the infection has spread to the periapex. So having a TOP positive case is not an ideal case for is an ideal case for root canal treatment, not for pulp capping. Okay, and there has to be no radiographic evidence of pulp pathology like widening of medial space or furcal involvement. Okay, and also you should not expect any root resorption or periradicular disease. So only in such cases you plan to go for direct pulp indirect pulp capping. Okay, so you see that this is the same procedure. I'll again repeat the same thing. In clinical procedure, this is a placement of calcium hydroxide or sometimes even a zinc oxygenol over the remaining areas for which helps in the formation of reparative dentin. Okay. What are the factors that affect pulp capping procedures? So age of the patient. So when you have an young patient, because of more amount of vascularity, you can achieve a good success rate. You can expect a good success rate with young patients. Whereas in older patients, as you know that there is good amount of fibrosis that takes place. So there is less chance of success. Okay, so young patients normally they respond better for pulp capping procedures, whereas old patients you have a very poor prognosis, so you go for root canal treatment. And type of exposure is also important. Whether what is the size of the exposure, whether is it a pinpoint exposure or it's a broad exposure. So the size of exposure determines the success rate. You have a very pinpoint exposure, you are going to achieve a good success rate, whereas when you have a broad exposure, you are going to have a poor success rate compared. And history of pain. If at all there is pain that occurs, certainly the success rate is poor. So only such cases where there is no pain, no tenderness to percussion should be taken. Even lasers are used in pulp capping. The carbon dioxide lasers, which is a soft tissue laser, can be used. This laser causes coagulation of the superficial layer and promotes healing. Okay, so even lasers also can be used. So let us now discuss broadly the various materials that are used for protection. One are conventional methods, the other one is recent materials. Conventional methods, you have varnish, base and liners. Okay, you have what are the bases that can be used? First we'll talk with varnish. Okay, you all know that varnish is a resin gum which is dissolved in an organ, either ether or chloroform. It also contains copal resin. So the main purpose of applying varnish is to seal the dentinal tubules, open dentinal tubules. It will seal it. So it is main acts as a thermal insulation. Okay, you apply 2 or 3 layers of varnish onto that. Okay, so by definition it is an organic copal or resin gum that is suspended in solutions of ether or chloroform. Okay, by this varnish is applied on the cavity floor and also on the walls of the cavity. Okay, this will help in the closure of open dentinal tubules and protect the pulp. So this especially varnish is used when the cavity depth is very less, when you have a very shallow cavities where base is not required. In such cases you go for varnish, and then you can go with permanent restoration like amalgam. So you should be careful that you are not supposed to apply varnish when you are planning to go with composite or glass enamel, because glass enamel is a chemical bonding to the tooth structure, whereas composite is micromechanical. Only with amalgam restoration you can apply varnish, whether the other two are the bonding mechanism is different, so varnish will not be of much help there. It is in the other sense it is going to affect the bonding of glass enamel and composite. Okay, next is liners. Liners are fluid materials that can adapt more readily to all aspects of the tooth preparation. They are used to create a uniform, even surface that aids in adaptation of more viscous filling materials. The problem with liners is that they don't have sufficient thickness, hardness, and strength. Okay, so they cannot be used in deeper penetrations. Okay. Till here we will discuss, we will again revise what has been discussed. We will discuss about the next slides in the next class. I will just to summarize, we have talked about what is indirect pulp capping, what is pulp capping, and what are the different pulpal irritants that can affect the pulp, and what is the importance of protection of the pulp. Okay, so with this I'll end my this session.